Topic of the lecture today is filarial infections. As the name indicates, filarial infections mean that those infections which are caused by filaria. Now that filaria might be microfilariae, that filaria might be adult filaria. Both of these can cause infections in a human being. We are not their main host, but we are their immediate host because they have to continue their life cycle inside the human body. They have to complete the life cycle by going through the human body, and they cause infection in the process. That's what we're going to study, these filarial infections. We're going to talk about what filarial infections come under the heading of this topic. First of all, we're going to talk about tropical pulmonary eosinophilia. Now, tropical pulmonary eosinophilia. Now, these three words came from very different origins. Tropical means those tropical regions in the world, tropical areas in the world. Pulmonary eosinophilia. Now, pulmonary eosinophilia was not collided till 1930s. They were properly different terms. Pulmonary infiltrates, eosinophilia, they were properly different terms. They were properly different pathologies. Until 1930s, when Lofflers went on and said they are somehow correlated in most of the cases. So pulmonary infiltrates and eosinophilia were first described together in 1930s. So once it was described, many other scientists jumped in and started studying it. And then the correlation between pulmonary infiltrates and eosinophilia were divided into 5 different kinds of pneumonias. Why pneumonias? Those pulmonary infiltrates were basically going towards the picture of pneumonia. So the scientists went on and divided them into 5 further subcategories of pulmonary eosinophilic pneumonias. First being the Loffler syndrome, second being the pulmonary eosinophilia, which is chronic, third being pulmonary eosinophilia due to asthma, fourth being para-arthritic nodosa, and fifth and the most basic that we're going to study right now is tropical pulmonary eosinophilia. Now they're actually pneumonias. If I have to define these pulmonary eosinophilias or pulmonary infiltrates associated with eosinophilia, I'll say they are chronic in some cases, acute in some cases, but they are basically pathological consequences. They are basically eosinophilia, which is associated with what? Damage of pulmonary parenchyma, or it can be blood eosinophilia. Right? So these two are correlated. So that's how we define them. So tropical pulmonary eosinophilia came into the being by Lofflers and scientists that went on. So what we do know is that it is associated with this pulmonary infiltrate, and this cause eosinophils. Now these eosinophils are found in the blood, or they can also be found in the lungs and parenchymal tissue. So once a patient is suffering from this pathology, what we are going to witness is these clinical findings. And what clinical findings might that be? First of all, the patient will have fever. Why fever? Because it's an infection. Because it's an infestation. And once there's infection or infestation, eosinophils, whenever there's parasitic infection or infestation, first bloodline that's going to rise is the eosinophils. So first of all, you're going to get eosinophilia. Second of all, you'll get fever because you're having an infection, acute infection in your body. So you will have fever, you will have cough. Why cough? Because it's practically destroying your pulmonary parenchyma. That's why cough is there. Because lungs are the target tissue for this pathology. Next on, weight loss. Why weight loss? Because of the active infection, because of the active infestation, because of malabsorption that happens due to multiple causes, the patient goes towards the weight loss. Next on, blood eosinophilia. We talked about it. Blood eosinophils will be the first marker to rise in the case of parasitic infection and parasitic infestation. Next on, you'll have serum elevated IgE. Why? Because whenever a parasite enters your body, it's not actually that parasite that's causing the whole damage. It's actually half of the damage is being caused by your own immune system. You get those hypersensitivity reactions. Those hypersensitivity reactions lead to further damage in your body. So when a parasite gets into your body, what's going to happen? Your body is going to respond. Respond how? First of all, eosinophils are going to rise. Second of all, your body is identifying this foreign material. This foreign material towards it's sensitized. So it will produce what? It will produce IgE. It will try to combat it, but what will happen in return? You will have these hypersensitivity reactions. And this IgE production will enhance, and you will get elevated serum IgE because of the present hypersensitivity reaction going on inside your body, plus the body is producing more and more IgEs. Next on, lesions in the lungs. Why? Because you are having this parenchymal destruction. Parenchyma of the lungs is being infested, so you'll have these lesions in the lungs due to this pathology, due to this infestation. And last of all, lymphadenopathy. Where do you think these parasites or these organisms go on and live? Basically lungs, and next of all, your lymph organs, your lymph tissues, your lymphatic system. So you will have lymphadenopathy because of what? Why? If there's parasite in your lymph system, why does it have to be lymphadenopathy? Because of their growth. Because of their growth. First of all. Next of all, they die in the process. Some of them die in the process. So when they die, what's going to happen? They're going to accumulate in your lymphatic system and eventually lead to what? In some cases, obstruction of the lymphatic system. In some cases, just lymphadenopathy, plain and simple. So these are the clinical findings that you will look for in a patient suffering from this pathology. Now going further into the details, you will have this cough and fever more at night. Why more at night? Because most of their metabolical system, most of their activity of these parasites and these organisms occur at night. So you'll have more of cough, more of fever at night rather than having it at daytimes. So once you're having these clinical symptoms, what are your differential diagnosis going to be? What will you think? Before jumping on to conclusions, before going into differentials, what you'll do is you'll start with history of the patient. You'll ask all the important questions, then you'll go on into the examination of the patient. You'll ask all the important questions, and having these symptoms in mind, you'll go for the differentials. And what differential might that be? First of all, you'll say it's asthma. Why asthma? Because pulmonary eosinophilia, pulmonary infiltrates, blood eosinophilia, these two are also present due to asthma. I told you when Loffler divided them into 5 subcategories, what happened? One of them was this tropical eosinophilia, and second of them was what? That was blood eosinophilia or pulmonary eosinophilia due to what? Due to asthma. So it has the same picture in asthma. So whenever you'll see pulmonary infiltrates like pneumonia and eosinophilia in the blood and cough, you'll go for what? You'll go for 2 differentials basically. Those two are asthma and this pulmonary tropical eosinophilia. So first of all, you'll think about asthma. Next of all, you'll think about Loffler syndrome. That was being the third symptom, right? That was being the third subcategory. Next on, you'll think about allergic bronchopulmonary Aspergillosis. That maybe it's an allergic reaction. Body is responding to it by raising its eosinophils, and we have this pulmonary infiltrates because it's allergy of bronchopulmonary origin, right? Next of all, you'll think about allergic granulomatosis with angiitis. That's also one of the possibilities in which you'll think that, okay, you are having this allergic reactions and all of these consequences are because of the allergic reactions. But it won't be like that. Next on, you'll go about systemic vasculitis. You'll think about it as a systemic disease. It's occurring everywhere. It's occurring in the lungs. It's occurring in the blood. It's occurring in the vessels. So let's name it systemic vasculitis. But moving on, you'll think about when you look at the X-ray of the patient, when you look at the lesions of the patient, when you look at the pulmonary infiltrates of the patient, what you'll see chronic eosinophilic pneumonia. So that's what you'll think. That was third subcategory after asthma, Loffler syndrome, and chronic eosinophilic pneumonia. Next on, you'll think about idiopathic hypereosinophilic syndrome. You'll think there's no reason for it. There's no correlation between these two. There's no correlation between hypersensitivity reactions causing eosinophilia and these pulmonary infiltrates. So you'll go on like it's idiopathic. So in all of these differentials that are coming to your mind, first 5 differentials must come from Loffler's and the scientists who decided and divided them pneumonias into 5 categories. Eosinophilic pneumonias into 5 categories. I told you already, I'll repeat it again for you so that you see them here one by one. You see them in the differentials one by one. First of all, Loffler syndrome, you have it right here. Second of all, chronic pulmonary eosinophilia, right? This is chronic pulmonary eosinophilia. Number 3, we said it can be due to asthma. Here it is, asthma. Number 4 being this pathology that we're talking about, and being 5th, this idiopathic origin. So whenever you'll see an image of a patient suffering from pulmonary infiltrates like pneumonia and having eosinophilia, you'll think about those 5 differentials. Next on, how will you confirm that which of these differentials is the right one? You will go on for what? You will go on for diagnosis. You'll go on for diagnostic modalities. Which of those diagnostic modalities are there? You will go for the antibodies produced in the body. You'll go for the blood testing in detail. You'll go for the detailed X-ray, MRIs. You'll go for the history, examination. All of these will coincide and lead you to diagnosis of tropical pulmonary eosinophilia. First of all, the region will tell you it happens in the tropical areas. Next of all, you will see the patient is suffering from pulmonary infiltrates and having blood eosinophilia, but never go for idiopathic until you have ruled out tropical pulmonary eosinophilia. So that being turned off, what is there next? You'll go for asthmatic checkups. Patient won't have any asthma. Patient won't have any breathlessness episodes. So what you think that likely it's tropical pulmonary eosinophilia. So you will start off the treatments. And what treatment modality is there to control tropical pulmonary eosinophilia? Let me tell you, in most of the cases, we don't even treat it. Why? Because its treatment in itself causes many pathologies. But in patients who are suffering from this disease for quite some time and are having some drastic effects on the body, they're going to get the treatment. How? They are going to get, they're going to get DEC, which is diethylcarbamazepine, which is given in 4 to 6 milligram per kilogram for 14 days. Now, 14 days is not a pet treatment. You can give it for you to remember, you can give it between 2 weeks to 3 weeks. From 14 days to 21 days, you give this dose to the patient which is suffering from this pathology. Now, what are the chances of getting this disease again? What are the chances that this disease will happen to the same patient again? 20% chances are there that this disease will occur again. Now, if the patient is chronic or getting this disease again and again and is not getting better, what's the treatment for that patient? Not different at all. You'll give exact the same treatment for not 3 weeks, not 2 weeks, but between 3 to 4 weeks. You enhance the treatment from 21 days to 28 days, and you continue this treatment and expect the patient to get better afterwards. Now, there have been multiple researches into it. into the treatment of it, that okay, its treatment is not healthy for the patient, so what should we do? They have multiple administrations of glucocorticoids for the treatment of the patient. Patient did get better. Patients do get better, but for some time, and then they get this disease again, so it's not a proper treatment. We went from albendazole, didn't work out. So pet treatment for this disease, whatever it is, whatever pathology it causes, whatever side effects are, we go for this DEC for 4 milligram to 6 milligram per kg for 2 weeks to 3 weeks in patients who are having this for the first time, and patients who are chronic or getting this disease again and again, we give it between 3 weeks to 4 weeks. Moving on to our next pathology, onchocerciasis. Now, what is onchocerciasis? It's actually a pathology, it's actually a parasite. You can see this parasite here, Onchocercia volvulus. You can see the horns of it, you can see the shape of it. Where does it come from? You might be thinking it's not like it's going to get inside our body on its own. So what is the vector for it? We're going to talk about its life cycle. So what happens is that this is a human body, you all know that. Black fly comes in and takes a bloody meal. Now it's not a healthy person, right? Keep in mind that this person which is being bitten or being taken the bloody meal from is not healthy, because his blood contains what? This. His blood already contains this larva. So what happens? This is taken up by this fly, this black fly, and this goes on into the system of the fly, and it propagates there. It enhances its strength. It goes on through its life cycle stages and then comes back into the human body. Now, for example, you are a healthy patient. Let's talk about the healthy patient now. You are a healthy patient and you are being bitten. What's going to happen? The black fly is going to come in, bite you on the skin, and then you'll leave. Now that bite contains what? L3 larva, mature larva. Now what's that L3 larva going to do? It's going to get into your subcutaneous tissue, and in subcutaneous tissue, adults are formed in the nodules. They're not going to stay there. They're going to go into the skin nodules, and they are going to get into the adult form. It takes months. It doesn't happen overnight. It doesn't happen in weeks. It takes months, between 1 to 5 months it takes for this larva, this L3 larva, to grow into its adult form. Now, all those L3 larvae which are not picked up somehow by human body die, because they need humans to evolve from L3 larva to their mature stage, to their adult stage. So they get into the nodules, they grow into adult form and do what? Then these adults produce unsheeted microfilariae that typically are found in skin and in lymphatics of connective tissue, but also occasionally in peripheral blood, urine, and sputum. Now, those adults, basically female adults, are going to reproduce. They are going to give off thousands of microfilariae overnight. Now those microfilariae can stay there. They can go to the skin, they can go to the tissues, and in some cases they're going to go into what? They're going to go into the blood. Why they're going into the blood is the most important question in their life cycle. How it's most important question? Because if these larvae are not picked up by the black fly, they are going to die in the blood. They don't have any means to survive. They have to be picked up by some black fly. So they go into the peripheral blood, they go into urine, they go into skin, they go into sputum, all of these. But what larvae or which larvae are going to grow into adults? Those larvae which are going to be picked up by the black fly. Otherwise they are dead. Otherwise, nor the sputum nor the urine, no one will do anything for them except the peripheral blood. Why the peripheral blood? Because that's where they get bitten. That's where they're taken by the black fly. Because you're sleeping at night or you're roaming around in the day, do you think the black fly is going to come in and sit on your chest? No, it's going to sit on your hands. It's going to sit on your legs. It's going to sit on your foot. That's where the peripheral blood is. So those black flies are going to pick them up from those sites, those peripheral blood sites. Moving on, these black fly takes a bloody meal, right, from the peripheral blood. They're going to take a bloody meal, which contains what? Which contains those larvas, which contains those microfilariae. Those microfilariae are going to penetrate the black fly's midgut and migrate to thoracic muscle, right? So they're not only affecting human, they're affecting the black fly itself. But black fly is acting as a vector here. So what happens is that with the bloody meal, they go into the black fly, get to the midgut, and in the midgut, they're gonna penetrate it and go into the thoracic muscles of the black fly. There, they have this L1 stage. Their microfilaria, they'll grow into L1 stage. From L1 stage, they'll go into L2 stage. From L2 stage, they'll go into L3 stage. Now, this process also takes months. So, from L3 stage, what's going to happen? They're going to stay there. They're going to wait that time period so that the black fly goes again to a person and bite them on the skin. And when they bite them, they're going to do what? They're going to go into human tissue. So these microfilarias converted into L1 larva, went to L2 larva, went to L3 larvas, taking months of it. From L3, they migrate to head and black flies proboscis, which are its thoracic muscles, which are where they bite from. And once they're there, they are going to go, take a bloody meal, and do what? Insert these L3 larvae in your body, in your skin. When they get into the skin, they go into your nodules, they grow into adults, they give off more and more of these microfilariae in your blood and body, and their cycle continues. So this is the whole life cycle of onchocerciasis, from which it goes on and on and on. Now, after learning about life cycle, what are going to be the clinical features of the patient? We talked about most of the cases, it's occurring in the skin. It's converting its L3 larva to the adult larva in our skin nodules, right? So skin manifestations or clinical manifestations which are regarded with skin will be like what? First of all, you will have papular eruptions on the areas which are being taken up by this, parasite. Next on, you'll have wrinkling of skin in those areas. It's taking most of your sources, it's taking most of your energy. Your skin is going to go into wrinkled form. Next on, you'll have loss of elastic fibers in the skin. Next on, you'll have pigmentation in those areas. In those areas which are being penetrated by these larvae, you will have pigmentation, which will lead to what? Dermatitis, in which it will be inflamed. Next on, you'll have hyperkeratosis. And last of all, you'll have epidermal atrophy. Epidermal layer will be atrophy. Now, these are the clinical manifestations regarding skin. Now, other clinical features will be like what? Let's talk about ocular tissues. Studies have revealed that there are 3 basic organs they are going to destroy. Those 3 basic organs are what? First of all, your skin. Second of all, your eyes. Third of all, your lungs. These 3 are the basic target organs for onchocerciasis. This onchocerciasis is also termed as river eye blindness. Now, river eye blindness means it causes blindness in the patient. It's called river eye blindness for 2 reasons. First of all, it causes blindness. That's what eye blindness is for. Why a river? Now, when you talk about the life cycle of black fly, their definite host is what? Their definite host is human, and their vector is what? That black fly. Now that black fly has to evolve, has to reproduce, has to go on. So they go on and give off their eggs in where? At what part? At fast flowing waters like rivers, Like any source of fast flowing water, wherever the fast flowing water is, there are chances it has there. The eggs are there. Why the fast flowing water? Because they need excessive amount of surface tension, excessive amount of oxygen for their growth, for their development, from egg to its form. That's what the river comes from. So river, eye blindness makes sense now, right? So they go on to the fast rivers or fast flowing waters, lay off their eggs, and it takes months. But after that, they can travel hundreds of kilometers back to their source. That's what they're there for. But now, as they can cause blindness, they are mostly found in tropical regions. Tropical regions being the rainforests of Africa, Nigeria, these are the areas which are affected the most. Millions of people get affected by it. Now, millions of people, like 40 to 80 millions, up to some estimate, are at risk of getting this pathology, getting this disease. Let me tell you, the blindness it causes is the second largest preventable blindness after trachoma. Now, we have heard about trachoma, what it does to the eye, how it causes blindness, but it's devastating that after trachoma, this is the second preventable blindness which we can prevent by what? By telling the people, by spreading the awareness. There's no proper cure for it, but we have to diagnose it at the early stage so that we can prevent it. Because if it has caused blindness, there's no going back. It's irreversible damage. If you catch it at the early stage, you can catch it, you can treat it, it can stop right there. But once it does its charm, once it goes through its charm, there's no going back. It's irreversible damage. That's why we have to prevent it. That's why we have to treat it before it goes on and causes blindness. Now, the ocular tissue will be presenting some features that you'll have to look for, right? It won't be like you don't have any ocular manifestations, you don't have any ocular symptoms, and suddenly you go boom, you're blind. No, you will have these clinical symptoms that people need to be aware of. First of all, you'll have lesions in the eye. There are lesions present in the eye. You have to go for your eye examination in those areas which are endemic for it more oftenly so that you can get diagnosed by it. You'll have conjunctivitis. You will have this punctate keratitis. Now, all of these symptoms will be telling you that it's going to happen very soon. So you have to get yourself checked up and get treated. Now, I told you there are basically three target organs like skin. We talked about the manifestations. Lungs, we talked about the manifestations. Then going on into ocular manifestations. Now, let's talk about the critical features which will be shown in the lymph nodes. Only one feature, lymphadenopathy. That is what you'll look for. Next on, let's talk about the systemic manifestations. We've talked about lymph node manifestations. We've talked about skin manifestations. We've talked about ocular manifestations. Now let's talk about the systemic manifestations that the patient will be presenting with what? Cachexia. You can see the patient, it's actually a definition of it. So this is what the patient will be presenting to you with systemic illness, systemic clinical manifestation. Now, how do we diagnose this patient? You can't just see a patient with cachexia and then you ask about 2 to 3 questions that, okay, your ocular manifestations look like this. It can be a bacterial infection. Conjunctivitis can be because of a bacterial infection. You have to be sure you go for the history of the patient. You'll go into detailed history. You'll ask about if there's any fast rivers with you, there's any black fly there. Now, black fly is not hard to spot. Males are between 2 to 4 centimeter, but females can vary from 5 centimeter to 15 centimeter in size. So you'll ask about the presence of black fly in their areas. You can ask about any other people being infected by it or any other regions which are closer to that place being affected by this parasite. You'll ask about all the detailed history. Then you'll go for the examination in which you'll look for skin manifestations like we talked about, this pigmentation, these eruptions, all of those manifestations you'll look for. Next one, you'll go for the eye examination. Next one, you'll go for the lymphadenopathy checkup, in which you will palpate all the lymph nodes. And once you're done with all of these, you will go for what? You'll go for diagnostic modalities, which will be what? First of all, biopsy of the skin. You'll take biopsy of those eruptions or pigmentation or whatever the stage the skin has now. You'll go for the biopsy of the skin. You can go for antibody assay. You can go for PCR, which will confirm your diagnosis. And once your diagnosis is confirmed, how do you treat the patient? First of all, you'll go for the surgical excision. Surgical excision of what? Surgical excision of those adult larvae which are present in your skin, in your nodules. So you go for the surgical excision, or in the medical treatment, you have to go for the medical treatment. You can go for ivermectin. And next on, you will tell that patient what? You will tell that patient that he has to prevent this disease from ever happening to him again. You will tell him all those measures which can prevent the disease. You can tell him to stay off. You can tell him to sleep in the room. You can tell him to put nets around his bed. You can tell him to stay away from that area. You can tell him to migrate from that area which is endemic. You can tell him all those things. And what a government can do is that they can spray in those fast flowing rivers, right? They can spray into those fast flowing rivers for these pathogens, for these parasites, for these eggs to kill. So this is all you can do, and this is all the treatment that you require for this pathology. Moving on, we have Loiasis. Loiasis is actually a funny name which has a funny origin. It's caused by Loa Loa. The parasite name is Loa Loa. So it's caused by Loa Loa. Let's talk about where does it come from. It comes from the exact same origin. It comes from mostly midges, flies. All of those can be involved in Loa Loa or Loiasis. So they can come on, they can bite you. They have the same life cycle as we talked about in the last slide. They have the same kind of life cycle. They come into human body, they go into the skin, they can stay there, they can go into the blood, they can go into peritoneal cavity, they can go into the pulmonary cavity. All those cavities can be infected, lymph nodes can be infected. All of the life cycle is the same. What is the difference here? Only the clinical findings. And even they are similar in some kinds. So what clinical findings you look for? Angioedema. It means blood vessels will be inflamed. You'll see redness on the skin. You'll see flushing symptoms. Next on, you'll have erythema. You can see erythema right here. It will be demarcated. The margins will be very clear. Next on, you'll have nephropathy. Nephropathy, why? Because of all these blood symptoms we're having, you're going to get to nephropathy. Your kidneys are going to get affected because of this pathogen. It's not because of any blood pathology or symptom, but due to the consequences of this parasite, you'll have this nephropathy. Next one, you'll have encephalopathy because it can go up to your mind, it can go up to your brain, it can cause this pathology and lead to encephalopathy. Next one, you can have cardiomyopathy because it can go to pericardial cavity and cause many pathological consequences. That's why cardiomyopathy is there. So it can cause cardiomyopathy, encephalopathy, nephropathy, erythema, and angioedema. So it can target multiple organs, as you can see, blood, heart, kidneys, blood vessels. All of these can be infected and affected at the same time. How do you diagnose it? Again, start from the history, ask those important questions. Where does he live? Where does he come from? Was he subjected to this kind of pathogen, or these flies or midges? Was he subjected to some kind of person who already had this disease? No, it's not from person to person contact, but it's just for you to know that the area where he is living is contaminated with this pathogen. Next on, you'll go for the examination. You'll go for the examination of the eyes. You'll go for the examination of the skin. You'll see for erythemas, angioedemas. you will go for the testing. Which testing you'll go for? First of all, you'll go for the basic testing. And basic testing involve what? Your blood testing, your renal function testing, your liver function testing. You'll go for what? You'll go for echocardiography for heart. Next on, you'll go for the MRIs or CT scan for your mind or your brain so that you get the stage of the disease. You get to know either it's affecting your brain or not. So first of all, you'll take the biopsy afterwards. Next, you'll go for antibody assay, and next PCR will be the definite diagnostic modality to use in this scenario. What are our treatment options? Just like before, you can go for DEC diethylcarbamazine, which is given in double the dose that we gave in tropical eosinophilia, right? You'll go for 8 to 10 milligram per kg per day, administered orally for 3 weeks. Now, second treatment is glucocorticoids. Now, glucocorticoids have proven to be effective in this pathology. They can be given in 40 to 60 milligram of prednisolone per day, followed by a dose of DEC. Now, DEC is not to be discontinued. It's also given with glucocorticoids because glucocorticoids might relieve you for some time, but it's not the ultimate treatment. On the other hand, DEC is the ultimate treatment, diethylcarbamazine. I'll repeat again. Next on, you can give albendazole. But albendazole is also given with what? Ivermectin, not alone. Albendazole is not given alone. You can give it with ivermectin. Now, you have streptocerciasis. Now, it's the fourth pathology that we're going to talk about in these filarial infections. Now, it is caused by human roundworms, which cause this infection. Now, human roundworms are those parasites which cause this pathology. So, roundworms can lead to streptocerciasis. Now, it's mostly found in the tropical regions like Africa and the rainforests. That's where it's from. They can cause this pathology, and the whole cycle is the same. We talked about in the last slides. It goes on, it will bite you, and those larvae will be injected, they'll grow into your body, and then they'll be picked off by the vector again, and this goes on, right? So those roundworms are mostly found in the tropical regions of Africa. Now, there they have been considered to be from chimpanzee. They think the vector is chimpanzee. This comes from chimpanzee of Africa. So whatever it is, whatever it might come from, what are the clinical findings you'll look for in a patient which is suffering from streptocerciasis? First of all, you'll have pruritus. Next one, you'll have papular rashes. Third, you have pigmentation changes. And fourth, inguinal adenopathy. So these clinical symptoms are evident to tell you that skin manifestations are involved in this pathology and lymph nodes, none other than that. They're not going to involve your ocular regions, they're not going to involve your cardial regions, they're not going to involve any systemic manifestations. They are going to have only what? They're going to have skin manifestation and lymphadenopathy, which is going to be most of the cases inguinal in nature. How do we diagnose it? You go for the history, again, ask about all those important questions. You go for the examination of the patient, in which you'll definitely look for skin manifestations, as well as you'll look for what? You look for lymphadenopathy in the inguinal region. Other inguinal regions, lymph regions can also be affected. It's not like only inguinal lymph nodes will be affected. You can go for the examination of all the lymph nodes, and then you'll reach your diagnosis. And then next on, you'll go for the diagnostic modalities, which are what? Which are to take the sample of the skin, or take the sample where you think it's affecting it. You can go for blood samples, and you have to identify the presence of microfilariae in the skin snips. You can take a sample of the skin areas which are having those pigmentation effects, which are having those eruptions, and you can go for the microscopic examination of the skin of those areas, and you will see multiple microfilariae, and these microfilariae will be associated with these adult forms of this pathogen, and then you will have your diagnosis confirmed. How do you treat it? Treatment is all the same. You can give ivermectin in this case. Now, mansonella perstans infections. Now, mansonella perstans infections are basically found in, again, those African areas, South African, Nigerian, and in some cases in Asian countries. Now, it can lead to what? It can lead to mansonellosis, which is one pathology. Now, this is the parasite right here, which confirms your diagnosis in most of the cases. Now, let's talk about this pathogen, this parasite. This parasite has the same life cycle we talked about in many of the cases. It will be given to you or transmitted to you through a vector. That vector can be a midge. That vector can be anything varying. It can be a black fly. It can be a midge. So they are going to inject those larvae. They are going to grow into your skin, into your nodules, into your systems, and grow into adult form. Now, one thing that's very differentiating and very particular about this pathogen or this pathology is that they are affecting the cavities of the body. They can affect the abdominal cavity, they can affect the pulmonary cavity, they can affect the peritoneal cavity. So this is a pathogen of cavities. So what happens is that these cavities will be affected. Then next on, they'll give off their microfilariae. Those microfilariae are going to travel in the blood, and those microfilariae are going to be picked up by the vector again, and that's how the life cycle continues. But what clinical findings you look for in a patient which is suffering from mansonella perstans infections? You look for angioedema again, you look for pruritus, you look for fever, you look for headache, you look for arthralgias, you look for hepatitis, you look for pericarditis. Now, I told you it's an infection of what? Cavities, right? So, abdominal cavity being affected will lead to what? Abdominal cramps, abdominal discomfort. Pericardial cavity being affected will lead to what? Pericarditis. Now, those joints or those nodules being affected will lead to what? Joints being affected will lead to arthralgias. You'll have fever because of the active infection. You'll have pruritus because of the active skin manifestation. Angioedema will be happening, and hepatitis will come in because it gives off your body to secondary infections. Those viruses can come in and cause hepatitis in return. Now, these are the clinical symptoms. What do you have to do for diagnosis? Again, go for the history, go for the examination. You look for all these clinical manifestations in the examination part that we just talked about. And in the diagnosis, to confirm your diagnosis, you have to go for the blood smear in which you'll see microfilariae, right? So the presence of microfilariae in the blood smear will confirm your diagnosis, and that's when you move on to the treatment option. What treatment options we have? You can go for doxycycline, which is given in 200 milligram twice a day up to 6 weeks in this patient. Next on, let's talk about Mansonella ozzardi infection. Looks like they're brother and sister, but they're not. They have rather difficult and different consequences, pathologically based and clinically based, and their clinical symptoms are very different from one another. So what is common is their life cycle. Life cycle is common for all these filarial infections we have just talked about. All those infections have the same life cycle, same kind of life cycle, just their vectors keep changing. Otherwise, they have the same life cycle. And no one is going to ask you about specific vectors of all those pathogens and pathologies, but you have to remember those black flies, you have to remember the midges, you have to remember those other chimpanzees we talked about. Those vectors are very important. Next on, this Mansonella ozzardi infection, this is what it looks like. What we look for in a patient after going through the life cycle, I just told you that it's going to the same life cycle we have talked about multiple times in the last slides. But what clinical findings will be there? How will we reach to a diagnosis? How will we differentiate from Mansonella ozzardi infection and the last Mansonella infection we talked about? So the clinical findings and symptoms will help us, in which we'll see headache, same. We'll have articular pain. We talked about it's going to happen in the last infection as well. Fever will be there. Hepatomegaly will be there. We talked about there's no hepatomegaly in that case, right? In some cases, hepatosplenomegaly is there, but hepatomegaly is a clinical finding, is a particular clinical finding for mansonella ozzardi infection. Next one, you'll have pruritus, you'll have eosinophilia, and you'll have adenopathies. Now, as long as eosinophilia is related or concerned, in all these infections, in all these parasitic infections we've talked about, you will see eosinophilia in every one of them, because eosinophilia is the first marker to rise in the blood after a parasitic infection. Now, adenopathy will be there, pruritus will be there. So it's not so different after all, right? They don't have any different symptoms rather than hepatomegaly. And that can also happen in the last infection. So, how do we diagnose it? On the basis of history, on the basis of examination, and specifically on the basis of microfilariae of ozzardi infection in the blood smear. That's how you differentiate it from the other Mansonella infections. Next on, how do we treat this patient? You go for ivermectin as well. The same treatment, same life cycle, same clinical findings. So you don't have to bother very much for getting the confirmed diagnosis, because the treatment is the same. Next on, we have dracunculiasis. Now, dracunculiasis is actually a roundworm. It is also called guinea worm infection. It is also called serpent. It's also called medina. All of these names are just for this one pathogen. Now, this one pathogen is mostly associated with guinea form and guinea worm. So it's called guinea worm infection in most of the cases. It's actually a nematode parasite. It's a vector-borne parasite. It's associated with nematodes. So it's found in only those areas which have stagnant water, which use stagnant water for their water intake, for their washing clothes, for their taking baths. All of these are found in those areas. So it's going to involve which areas? Rural areas, backward areas, which don't have any water supply, which don't have underground water to support them for maintaining their life. So they go on for stagnant water, they go on to those areas which have this water supply due to the rains, and this water has been stagnant for many lifetimes. So they go on and use that, and that's where this disease comes from. As you can see, dracunculiasis, this is a depiction of this pathogen. Now, why it's on the foot? Only the legs and the foot, or you can see the feet, are going to be affected by it. They are going to move under the skin into subcutaneous layers, and they're basically found in the legs and the feet. So they are found in the legs and the feet, and next on, they are found in the subcutaneous layers. They can also go to the head, they can also go to the neck, but most of the cases that you and I are going to see or going to encounter are going to have this area being involved and this skin layer being involved. So let's talk about the life cycle of dracunculiasis before we move on to the clinical symptoms of it. Now, this is caused by stagnant water. How will this cycle go on? Let me tell you. Maybe I'm the patient which is suffering from dracunculiasis. This pathogen moves through the legs, crosses all the skin barriers, gets to the external surface, and causes this severe itch. That itch is only resolved, or that itch only goes away when you put some water on it. So I'll run off and go into the nearest pond or go into the nearest stagnant water, and I'll put my feet into that water. Now that will relieve my symptoms for some time. That will relieve my pain for some time. But it's actually a technique for them. That time, at that second, they'll release millions of microscopic eggs in that water. Millions of them. They'll release millions of their offsprings in those stagnant waters. Now, I'm relieved, I'll go back, but those millions of the offsprings are there. And they are engulfed by what? An intermediate host. And what is that intermediate host? Cyclops. All those offsprings which were not taken up by the cyclops are going to die. So the only ones that are going to survive are the ones which are taken up by the cyclops. There they complete half of their life cycle, then they come back, and you know what? You go on and use that fresh water again, that stagnant water again, and you'll get this pathogen in your system. You'll drink that water or put it in the food and cook that food with that water, and then you'll eat that food, and somehow it will gain entry to your system. It will go to your midgut, it will penetrate your midgut wall, it will go on and move to the skin layers and start spreading there, start growing into the adult form. Now, the males have a size between 2 to 4 centimeter, but the females have a size of whooping 10 to 55 centimeter. So they're very easy to diagnose, because a patient suffering from dracunculiasis, you can actually see the worms moving under the skin. You can actually see it happening because they're that big inside and they're present rather superficially. So as we've talked about the life cycle of it, let's talk about what clinical findings you'll look for in that patient. First of all, you'll go for the edema. Next, you'll have wheezing. Why wheezing? Because it's affecting your pulmonary system. It's affecting your pulmonary system. It's causing many of those hypersensitivity reactions in your body, and that will lead to what? Bronchoconstriction. And when bronchoconstriction will come in, you will wheeze and you will need more and more of oxygen. You'll go on the oxygen pumps, or you'll go for the bronchodilators, whatever suits you. Next on, there will be urticaria, because of skin manifestation. It's present right under your skin. It can cause many skin manifestations regarding and including urticaria. You'll go for the tetanus. Why? It can lead up to that. Tetanus is one of those clinical findings that you will have in this pathology. I know it's very drastic, but one might get it. Next on, you can have cellulitis in those areas which are being affected the most. Next on, you can get abscess formation in those areas. And last of all, you can get an ulcer formation. And these ulcers are where? Mouth. Your mouth ulcers, basically. They are one of those clinical findings you look for at the early stages. So, dracunculiasis is actually very lethal pathogen, right? Very lethal pathology. It can lead up to tetanus, cellulitis, abscess formation, ulcer formation. Now, all of those might not be life-taking, but tetanus and cellulitis are. And maybe they don't kill the patient. Maybe they don't kill that patient which is suffering from it, but they definitely cause the disability for life. That's one thing to remember. They cause disability for the lifetime. Moving on to its diagnostic forms, let's talk about its diagnosis. You will confirm the diagnosis how? You'll see those larvas, those filarias, those adult larvas moving under your skin. You will see them in your eyes in some cases. That's how you will diagnose them, and you'll go for the treatment, and the treatment is the same. You will have to look for the patient. You'll have to know what kind of pathogen is there. Once you have diagnosed it, you'll go for the treatment modalities, which are not so different from other parasitic infections. You'll go for the ivermectin, you'll go for the albendazole, albendazole, and if it's suitable to the patient, you will go for DEC. Next on, let's talk about zoonotic filarial infections. Zoonotic filarial infections mean those filarial infections which occur because of zoonotic origin. And they include what? Diarrhoefilaria. It's depicted here, right here. It's the main cause of it. So the clinical findings you'll look for in the patient which is suffering from this pathology is chest pain, hemoptysis, and lymph node enlargement. Why? Why chest pain? Why hemoptysis? Why lymph node enlargement? Because it's affecting basically three basic organ systems: lungs, your blood vessels, and your lymph nodes. So due to lungs, you'll have this chest pain, you'll have this discomfort because of the blood involvement, because of the angio involvement. You will have these hemoptysis episodes, and next on you'll have this lymph involvement, which will lead to lymph enlargement. How do we diagnose it? How do we treat it? You diagnose it on the basis of skin biopsy again. You will take for skin biopsy, you can go for the assays, you can go for the PCR. That's how you will diagnose this pathology. And once you have diagnosed it, you will treat it with ivermectin, and you can go for the DEC, and in some cases, albendazole and mebendazole is given in this patient. So that's all for today. Thank you for watching scardia.com.